Are you curious about Gestalt language processing? You are not alone. Join me, Corinne Smoose, and speech therapy PD for our podcast, The Gestalt Get Together. Our episodes try to balance the enthusiasm and excitement about GLP and its associated intervention ideas, as well as a healthy dose of skepticism about how to understand and integrate this paradigm shift into your career and the field at large. We hope that you can get together with us to learn more about Gestalts.
Welcome to Brainstorms, Functional Neuro Rehab for SLPs, presented by SpeechTherapyPD.com. This podcast is designed for the adult medical speech-language pathologist. Most of our audience members work in settings such as acute care hospitals, private practice, outpatient hospital clinics, and inpatient rehabilitation hospitals. Each episode has an accompanying audio course on SpeechTherapyPD.com and is available for 0.1 ASHA CEUs. The content of this course is based on the research and experience of the presenters. The listener is responsible for researching to determine if the information and skills taught are appropriate for their clients, students, or patients. SpeechTherapyPD.com does not necessarily endorse, recommend, or favor the information shared, nor any of the claims, opinions, statements, offers, or services made by the presenter.
Hello and welcome, everyone. My name is Renee Garrett, and I'm your Speech Therapy PD podcast host for Brainstorms, Functional Neuro Rehab for SLPs. Before we get started, we have a few items to alert you to. Each episode is 60 minutes and will be offered for 0.1 ASHA CEU. Here are the financial and non-financial disclosures. Lynn Reed is a full-time salaried Kessler Institute for Rehabilitation employee in West Orange, New Jersey. She also receives a speaker fee contracted as a faculty member/lecturer for the Concussion Corner Academy online course. Lynn receives an honorarium from Speech Therapy PD as a guest on this podcast. Her non-financial disclosure is that she is the New Jersey State Representative of the National Aphasia Association. My financial disclosures are that I'm a paid employee of a private consulting firm in the Commonwealth of Virginia. As the host of Brainstorms, Functional Neuro Rehab for SLPs, and other webinars on Speech Therapy PD, I do receive financial reimbursement. My non-financial disclosure is that I'm the secretary for the Communication Disorders Foundation of Virginia. Now, without further ado, we welcome our guest, Lynn Reed, MA, CCC-SLP, CBIS, MSCS, who is a licensed speech-language pathologist working at the Kessler Institute for Rehabilitation's Outpatient Cognitive Rehabilitation Program. She has over 20 years of experience in acute rehabilitation and outpatient settings, focusing on neurological impairments, including traumatic brain injury, stroke, multiple sclerosis, Parkinson's disease, MCI, dementia, and cancer-related cognitive decline. Lynn is a certified brain injury specialist and multiple sclerosis certified specialist with additional certifications in LSVT, speak out, and vital stimulation. Welcome, Lynn. It's so nice to finally meet you.
Thank you so much for having me, Renee. I really appreciate that. So I'd like to, get started by talking about what multiple sclerosis is. So basically MS, it's a chronic inflammatory disease of the central nervous system. And its hallmarks are in demyelination and axonal degeneration. So in MS, your immune system kind of mistakenly attacks myelin cells. And these are the protective covers or the sheaths. So if we think back to when we were in graduate school, right, remember like the myelin sheaths, that they surround the brain and the spinal cord nerves. So to kind of provide a little bit more detail, these autoreactive T helper cells, they're Th1 and Th17. They have this initial contact with a yet unknown antigen because there really is no definitive cause for MS at this time. All we know is that these helper cells have this initial contact with this yet unknown antigen. So basically, this leads to production of what we call pro-inflammatory cytokines called interleukin and interferon. And from what we know from the literature, if all of you are keeping up with your journal articles, we know that in any type of inflammation is not good, right? So the production of these cytokines then leads to further of those T helper cells, upregulation, and then eventual destruction of the blood-brain barrier. So what is the blood-brain barrier? It's basically a layer of cells that acts as a filter. And it's supposed to keep harmful substances and pathogens out, but keep the beneficial chemicals in. So once this T helper cell migrates into the central nervous system, crossing that blood-brain barrier, that's when we see the myelin sheath and those axons, they kind of become targeted. So again, once that blood-brain barrier gets breached, the immune system winds up attacking the myelin sheath. And then this attack causes swelling and inflammation, which we don't want, and then injury to the myelin sheath. So ultimately, the nerve fibers that the myelin sheath surrounds become damaged. And the process can result in areas of scarring, which is known as sclerosis. So usually people with multiple sclerosis will have multiple areas of that scarring, and that's the reason why the disease is known as multiple sclerosis. So a little kind of fun fact on the name there. So damage can take place in the brain and or the spinal cord. Typically, though, with spinal cord lesions, someone with MS might have more numbness, they might have tingling, muscle weakness, and pain, whereas someone who has more lesions in the brain, they might have symptoms that involve vision, coordination issues, and then also a decline in cognition. I've worked with a woman who, when she has a flare-up of her MS, sometimes she'll just completely lose vision in one of her eyes where she can't see anything. And then once that remits and she's treated with some corticosteroids, her vision usually winds up coming back. So there can be a pretty big distinction between if you have more lesions in your spinal cord versus in your brain. So as I mentioned before, there really is no definitive cause but some studies have implicated vitamin D deficiency. And I'm going to talk about that in a couple more minutes. Diet and obesity early in life can also be considered a potential cause for cigarette smoking. The Epstein-Barr virus can also be implicated. And then they're also looking at the HLA region of chromosome 6. So chromosome 6 has been implicated in the development of hundreds of human diseases, including most autoimmune diseases. So that's the reason that one's being investigated. So I mentioned before about vitamin D deficiency. So I found this kind of interesting. If we were to look at a map of the world, there's actually a higher incidence of MS the further away one lives from the equator. So people who live in like those higher latitudes, they experience less sunlight half of the year than people who live near the equator. And one of the natural ways that we actually get vitamin D is from sun exposure. So it's kind of interesting how the researchers are looking into those environmental factors along with those genetic factors that could potentially lead to MS. So MS affects 3 times more women than men. However, usually when men are affected, sometimes their symptoms can be a little bit more severe. And most people with MS develop the disease usually between the ages of 20 and 40. So this is really a young person's disease. And I guess when we're talking about therapy with this population, we kind of want to take that into account. These people are basically in the prime of their lives, and they're being told now that they have MS. And they're being told, what the prognosis and what the outcome is going to be. So we need to kind of take those psychological factors into account when we're treating our patients. We need to remember that no 2 people with MS are alike. So if anyone's treated people with MS before, you might see some similarities, but overall, they're all going to be very, very different. So their outcomes are going to be heterogeneous, and it really depends on where in the central nervous system that demyelination and that axonal degeneration takes place. So if I can just briefly go through just the different types of MS. I think most people have heard of primary progressive and relapsing remitting, but there is a new category that most people are not familiar with at this point. It's called clinically isolated syndrome. And this is actually considered a type of MS. It's kind of a precursor, but at the same time, it's also considered a type of MS. So it's basically that first episode of MS inflammatory demyelination that can then turn into one of the other types, such as the relapsing remitting or, say, a primary progressive. So clinically isolated syndrome lasts at least 24 hours and is caused by inflammation or demyelination, which is that loss of the myelin that covers the nerve cells in the central nervous system. So when you think about somebody who has this quick onset of symptoms, they show up to the emergency room, you can kind of see how they might be misdiagnosed initially. Maybe they think it's a TIA, maybe it could be a stroke. So people who are able to get to a really good medical facility where there is someone there that knows a lot about MS, they can really kind of do a deeper dive on this and come up with a diagnosis. But clinically isolated syndrome can be either monofocal or multifocal. So monofocal would mean that there's only one symptom or neurologic sign, whereas a multifocal would obviously mean that there's going to be more than one symptom that they're experiencing. Moving on, there's relapsing remitting, which is probably the most common that most people are familiar with. And this means that the person with MS may get an exacerbation of their symptoms, and with time and with treatment, and it's usually from corticosteroids, those symptoms do resolve, or they're at least reduced in severity. And this type can be what they call active, where there actually is new evidence of a new relapse. They'll take, an MRI and they look to see if there's any new gadolinium enhancing lesions or a new or enlarging T2 lesion over a specified time. So relapsing and remitting can be not active in that there might not be any new evidence of the disease activity. So it's kind of interesting how it can be classified as being active versus non-active, but yet they're still experiencing those types of symptoms. And relapsing remitting type also gets classified as either worsening or stable. So obviously, as a physician who's treating these patients, you want to try to keep your patient as stable for as long as possible. But we do know that for some people with relapsing remitting, over time, as their case kind of worsens, they can develop more progressive symptoms. So the next type I want to talk about is primary progressive. So this means that the disease process worsens over time without the relapses and the recovery of symptoms. So as speech language pathologists, we might be familiar with like primary progressive aphasia, which means that it gets worse over time. This is the same type of situation just with MS. Really no relapses and remitting, it just kind of gradually keeps getting worse. And then the last type is called secondary progressive. And what I mentioned before about the relapsing remitting, this is basically what happens. Someone who's had relapsing remitting for a period of time, their symptoms kind of get worse over time, and it can become more progressive in nature. So unfortunately, there is no cure for MS, but it can be treated with what we call disease-modifying therapies called DMTs. And these DMTs can reduce how many relapses someone has, how serious they might be, and they can also slow down the damage, which is caused by, most times that relapsing multiple sclerosis that builds up over time. There are actually numerous DMTs on the market right now for MS. If any of you watch the news in the morning, where during the commercials, all they seem to show is all these different ads for advertisements for all these different medications. Sometimes you might actually see one for MS, but there's so many more now than there were about 20 to 30 years ago. And I'd say initially, most of the medications were really just for the relapsing remitting subtype, but now there are some on the market that are now for the more progressive types too. So these types of therapies, they can be injectables where the patient would actually self-inject. They can be in pill and oral form, or they can be given via infusion. So just kind of keep in mind for any of us who have been treating our patients or our clients, and we give them homework to do, and sometimes they don't always follow through on their home exercise program. Same goes for for somebody with MS with their compliance with their DMT. So in the beginning, there were almost all of the therapies were injectables. So if any of you know anyone who needs to check their blood sugar using finger sticks, you know that they experience the tenderness and the bruising. And same goes for people with MS. So there tends to be better compliance now that they have pill form, or sometimes they can also get infusions that can be spaced out so that they're only getting an infusion maybe just a few times a year. So it's a lot more patient friendly now to be treated with MS than it used to be maybe 20, 30 years ago. So a DMT that is prescribed is usually carefully chosen by that person's neurologist or other physician that's just extremely knowledgeable about MS. And I just want to mention one other thing for as far as like a treatment for MS, and that actually has to do with marijuana. As we know, marijuana is being made legal in many states across the country now. So for the first time, cannabinoids are actually being researched as an alternative method for treating spasticity and pain in MS. So basically, depending on the location and the number and the severity of lesions from MS and the progression of the disease process, you can see how speech and swallowing and our cognitive communicative skills can all be impacted. And this is where the SLP comes in.
Yeah, that's kind of where I was going to jump in, because I know when I worked in acute care, we had a patient who came in over the course of the time I was there for 10 plus years. We had a patient with a very rare form of MS who would come in, and she had all kinds of issues from cognitive stuff to swallowing stuff. And it was really a learning experience. And then when I went to the outpatient setting, I had more patients with the cognitive issues that they were concerned about, just really looking more for strategies. But most of those patients had relapsing remitting. So they would experience, like you mentioned, these exacerbations where they were more reliant on strategies, or maybe they hadn't been consistently using strategies because they didn't feel like they needed them. And then, kind of had that moment of like, oh my gosh, what am I going to do now? Because I'm having this new thing, but I've had this before and I don't remember what to do with it. So I think that's a great space to say, why should we be familiar with this? Because it can happen, like you said, a younger person's disease for the most part, but we also see people who get diagnosed later in life. This particular gentleman was in his 60s and about to retire. He owned a business and was sort of moving into this role of consultant / contractor versus running the business. And so for him, it was very kind of shocking, really off-putting for him. He didn't really know how to handle it. And so there was a lot of counseling component there in addition to the cognitive strategies and cognitive therapy pieces.
Yeah. You kind of touched on a point there that there's definitely a psychological component that we need to really take into account. And if you can refer your patient to any type of psychological counseling, especially somebody that might have a little bit more experience in working with people who've had neurological impairments, that would probably be really helpful. Yeah.
Yeah. And we're fortunate, a lot of us that have worked in inpatient rehab and even in outpatient settings, we have neuropsychologists that we've worked with, in different places and spaces. But the funny thing was, when I went to inpatient, or from inpatient to outpatient, I had a neuropsychologist that I worked with very early on in my career who also had moved into the outpatient world, and we hadn't really talked in quite a few years. And she sent me quite a few referrals when she found out I was in an outpatient setting for exactly this, because she, kind of trusted that I was going to do my due diligence and making sure that my competencies were up to date and I was providing the best care I could possibly do. And if I wasn't sure, then I would, refer to someone else that had more experience in treating this patient. And not to be confused with, because I teach a TBI class right now, and one of my students asked last week or pointed out that we're not able to directly refer. And I said, oh, well, when I say refer, I mean refer to another SLP who has more competency and experience in this particular area versus, yes, of course, we have to go through the primary care or the neurologist or whatever other specialists we're working with if we need a referral to someone else. So just to clarify that.
Yeah.
But I think that's a great space to say, why should we be familiar with all of this treatment methodology as far as knowing what those aspects are? Because it's a lot.
It is. And you're absolutely right. So I will tell you that according to the MS Society, around 25 to 40% of people with MS may experience changes in their speech production. So that's just the speech production. So this could be dysarthria, it could be dysphonia. Our patients could have changes in muscle strength and coordination that can lead to changes in their articulatory precision and their intelligibility. Could also impact their coordination of the breath support and voicing. So sometimes people with MS, their voice might sound a little strained and strangled. Sometimes it can sound a little harsh, hoarse, or breathy. And so in those instances, like therapy would really consist of a combination of like targeted exercises, obviously tailored to each person's deficits. And as you mentioned before, as well as training the person on compensatory strategies. Because what we do know, unfortunately, is that this is a degenerative disease process, right? So we can certainly do exercises with them, but they also need something to kind of fall back on. If they start to progress, they need to have those strategies kind of in their back pocket to be able to pick those things out. But if I can just kind of give like a quick example of just like some really nice voice exercises. So if you have somebody that's having difficulty with being able to project their voice, one of the things I'll talk about a little bit later is that people with MS, they experience a lot of fatigue. So if they're having difficulty with their voice and they feel like they're constantly having to use a lot of effort to speak, they're going to get tired really, really quickly. So we need to be able to not only teach them some strategies, but there are some exercises that we actually can do with them. So one of the voice exercises is called semi-occluded vocal tract exercises. And they could include like your lip trills where, excuse me while I do this. And the reason that you want to have your patient do that is because you want to get them nice and forward, as opposed to kind of concentrating back here in the back of their throat. You want them nice and forward. Sometimes you can have them vocalize and make some sounds, actually using a straw. Sometimes it's called straws therapy, where you put the straw into a cup and then you kind of have them hum. And again, it kind of has the patient get that feeling of being able to keep their resonance a little bit more forward than back. And the benefits of this would be obviously reducing that vocal fatigue, but it also improves their vocal efficiency. They might have just a clearer sound, and it's a really nice, gentle vocal cord stretch for them. And as I mentioned before, fatigue is a really significant issue for people with MS. So training them to use their voice more efficiently with less effort is going to be really very important to them. And then also, on the flip side, it's teaching them those compensatory strategies. And sometimes it's easier said than done, right? So we can all tell our patients to reduce the rate of their speech, to increase their intelligibility. But I always tell my patients, yeah, it is hard to think about what you want to say and how you're going to say it at the same time. But just being able to help them, you can record them, do some audio feedback to show them that they're actually much more intelligible when they really do focus and concentrate on reducing that rate of speech. And even maybe just focusing on coordinating that adequate breath support so that they have that good, strong voice. And then the other area that you brought up, Renee, and that's kind of where a lot of what I'm going to be talking about is people with MS often encounter a decline in their cognitive functioning. And the research shows that roughly about 65% of people with MS will probably experience some cognitive challenges. Sometimes they're aware of it, sometimes they're not. Obviously, it's like any other patient that we work with. Insight is going to be variable. But typically, the most common skills impacted that we see are processing speed, attention, memory, executive functioning. And then I do have a lot of patients who report word finding issues and some language issues. And when I refer to language, it's really more their organization of their verbal output. So just to do a really quick review of these cognitive skills, basically our information processing, it's It's our brain's ability to synthesize information gathered by our senses. So what we take in visually by our sense of sight, our hearing, smell, everything. But keep in mind that due to the damage of that myelin sheath, right, in multiple sclerosis, those signals get, and that's what causes that reduced speed of processing. Also, attention, it's that cognitive process that allows us the ability to kind of select and focus on what's important in any given moment, right? And again, this could be verbal or visual. So it could be paying attention to what others are saying, like in a Zoom call, such as this. Or from a visual standpoint, it could be just finding our favorite brand of cereal in that ever-expanding aisle of choices at the supermarket. Believe it or not, that actually requires really good attention skills to be able to kind of hone in on that. If any of you have ever been away and you've had to go to a different supermarket and you're not used to the layout, visually, you really kind of have to take a moment and really focus and attend to what you really need.
Oh, that's funny because I say that here about our local supermarket when they rearrange the aisles. I'm like, why would you do that? You just made my whole day worse.
Exactly. And then there's memory, right? So memory, it's that ability to acquire, retain, and recall information, right? And so there's those 3 stages. First is encoding, the next is storage, and then the last is retrieval. So encoding is taking information in from the environment and making sense of it, and then basically deciding what to do with it. So you can see how that encoding is going to be tied to that speed of processing. The next is storage. So it's basically taking that piece of information that you've just processed it and filed it somewhere in that filing cabinet in your head. And then that last stage is retrieval. It's being able to pull that information out of that filing cabinet when we want it. And that's what most of us have difficulty with. It's that retrieval piece. It's that, what's that person's name, or what's the name of that street? It's usually that retrieval. But for people with MS, their difficulty is the encoding stage. It's that beginning stage, right? So that's why I said, it kind of makes sense that it's tied to that information processing and then that speed. And then another area of cognitive difficulty is for our MS clients is executive functioning. They get overwhelmed very, very easily. When I try to explain executive functioning to my patients and their family members, I just say, think of like a conductor of an orchestra, right? He has to make sure all of the flutes and the violins and the clarinets, they're all playing in time so that the orchestra as a whole sounds really good. That's basically what our executive functioning skills do for us. They kind of oversee and monitor the other cognitive skills in order to work together so that we as a whole, as a person, can be productive and efficient. So again, now if you're having difficulty with your attention and your processing speed, it's going to affect your executive functioning skills. And then that last cognitive skill that people with MS typically tell me that they have difficulty with is their language and their word finding. So we, as speech language pathologists, we all know how important all types of communication are. People with MS may have difficulty organizing their thoughts. So a lot of times their verbal output is very verbose and tangential, or they may have difficulty with word finding and their pragmatics. I still remember working with a gentleman who had MS, and he just took the roundabout way to kind of get to his point. And finally, I just put the acronym KISS down, and I just said, keep it simple, silly. And just trying to tell him, you don't have to give that much detail. Just give me the basics. That's really the most important thing. And he says, oh, now I got it, Miss Lynn. He goes, you just want the short version. So just kind of something to keep in mind when you're trying to work with your patients, because I know sometimes that the pragmatics and the verbosity and being tangential, sometimes patients can take that as you're accusing them that there's something wrong with their personality, and it's not necessarily their personality, it's really just the organization of their thoughts. So by kind of just teaching them, I just need to know the who, the what, and the why. Maybe the where and the when are important too, but I just really need to know who we're talking about, what the situation is, what the problem is, and why are you telling me this? Why is it important?
Well, and I think that's a good, tie in back into executive functions, because we know if with executive functions, if there is a deficit in self-regulation and self-monitoring, it trickles down into all those examples that you're giving. And this is what I taught my TBI class this morning, and that's exactly what we talked about, was that self-regulation impacts all these other things: the organization, the planning, the word finding, being able to complete a task initiation, and all those components that we sort of forget about when we are typically functioning adults who work and live and breathe and parent and go to the store and drive, and all those tasks that seem so simplistic that we do daily, until you break those down into steps for people that are now having difficulty with those.
Absolutely. Absolutely. And all of these skills can be treated, directly via therapy tasks and exercises. But as I mentioned before, we know that MS is a degenerative process. So we want to train our patients in those compensatory strategies, and that should always be a part of our treatment. I do have an evidence-based treatment that's specific to people with MS that I would like to go over.
Oh yeah, for sure.
Yeah. So there aren't that many. I don't know if any of you have done a literature search, but there aren't too many. And I do find that in addition to there not being that many out there, the average speech language pathologist doesn't always have access to them, because sometimes it could be a copyright issue or it's just a proprietary type of issue. But sometimes you'll read this great article and you think, oh, this is great, I want to use this, but then you don't really have access to it. So as we start talking about therapy, I'm going to talk about one particular evidence-based treatment for MS. And it's the same type of situation. It was developed at the Kessler Foundation, which is the research arm of the Kessler Institute. But I can at least go over the study with you and kind of walk you through like the protocol, and hopefully that might be helpful to you. But again, since there are these limited evidence-based treatments, we need to use our own skills, right, and our knowledge to provide functional activities for our clients that target these underlying skills and deficits. So don't underestimate your own skill if you don't have access to some of the evidence-based things. So the one I'm going to talk about, it's called the Modified Story Method Technique, and it was developed by Dr. Nancy Chiavarlotti. She is a neuropsychologist at the Kessler Foundation in New Jersey. And the technique was initially designed to target memory issues in MS, but more recently, she's expanded this to also include processing speed. But I figured, just for simplicity for this evening, I'm just going to review the study that targets the memory, because I feel like that's one thing that people with MS usually talk about, is they talk about their memory.
Yeah.
So this was a double-blind, placebo-controlled randomized trial of 86 subjects with MS. The subjects were seen just 2 times a week for about 45 to 60-minute sessions for 5 weeks. So they got 10 sessions. And the modified story method technique, it trains 2 related skills: imagery and context. So imagery means that we're able to visualize something like an apple, right? So I might picture an apple, somebody else might picture an apple. Maybe mine is red, that person's is green. It doesn't matter. We both know what an apple is, but we need to have that visualization in our head. And then the context refers to the supporting information describing a word or an idea. So the first 8 sessions are just on training the skills of imagery and context. And basically it's using a training manual that basically has scripts for the clinician to follow to be able to train the person in a very systematic way and how to use imagery and context. And then sessions 9 and 10 focus on applying those skills that they learned in the first 8 sessions to those real world type of settings. This study actually did have booster sessions, and the booster sessions were provided basically to determine if there was generalization of the strategy. And basically what they found was that on functional MRI, it showed an increase in activity after treatment only in areas underlying the treated function. So for example, they showed increased connectivity from the left hippocampus to the insula bilaterally in the treatment group after treatment. It also showed increased connectivity from the right hippocampus to a cluster comprised of the left postcentral gyrus, the precentral gyrus, the middle frontal gyrus, and the cingulate gyrus in the treatment group after treatment. So that's the supporting evidence from imaging. And if we know anything about our neurology, we know that the hippocampus, which is basically around our ears here, is extremely important in memory. And if those of you have ever worked with anybody who's maybe had like cardiac arrest or has had like a lack of oxygen to their brain, they usually have difficulty with their memory because our hippocampus is what I call like an oxygen hog.
Right. Yeah.
Yeah, it likes, it takes in like roughly 25% of all the oxygen that comes up to our brain. So when your hippocampus is denied that oxygen, you're definitely going to have some issues with memory. But in addition to the imaging, they also did formal diagnostic assessment. So they showed that scores on the California Verbal Learning Test increased by a higher degree in the treatment group as compared to the placebo group. And then they also did some pro outcomes, which I thought was kind of interesting. So they used what's called the general contentment section from the FAMS, and the FAMS stands for Functional Assessment of Multiple Sclerosis, as well as the Frisbee, which is the Frontal Systems Behavioral Scale. And scores on those pro outcomes increased more significantly in the treatment group compared to the control group. All right, so now that you've listened to all of that, let me try to go through this protocol with you now. So in sessions 1 to 4, 1 to 4 kind of really focuses on training the person to use imagery. So basically what the client winds up doing is they read a story that's given to them containing scenes that the client can easily visualize, such as like someone pulling an apple from a tree. Following 100-second exposure to that story, the client can then try to recall bold, capitalized words from that story that was provided to them. Then the therapist provides cued recall and is tested by presenting contextual cues to recall the story details. This procedure is then repeated with the same story, okay, with additional instruction and examples to facilitate visualization provided by that therapist, because they really want that patient to truly get a visual image of this story actually happening. And those key words that have been bold and in capital letters for them should hopefully stand out for them. So once the completion of those questions, those recall questions is done for a second time, that session was concluded. And then when the person came back for sessions 2 to 4, new stories were presented with increased complexity. So as you can see, those first 4 sessions really just concentrated on teaching imagery and visualization as a strategy. Then we get to sessions 5 through 8, and the session format changes, such that the participant is presented with just a list of words rather than a story. Now the client is instructed that they have to incorporate that list of words and they have to create their own story. So they're instructed to kind of visualize their story to aid their memory. They're building on those skills that they learned in sessions 1 through 4. Again, there's free recall and recognition questions are followed to see how much they can remember of those words. And then following additional instruction and examples, that procedure again is repeated with the same word list, again, really trying to solidify the development of that story, given those words and to develop the context. So again, that same procedure again was followed for sessions 6 through 8. Each time the client is given that new list for each session, with each list having decreasing interrelationships among the words in the previous one, making it a little bit harder for them to kind of come up with a story to kind of connect all of those words together. So really kind of challenging the person's brain to be able to do that. So again, you can see the focus of sessions 5 through 8 is to teach the client how to develop their own context to remember important information later on. Then we get to the last 2 sessions, 9 and 10, and the client is asked to use the 2 skills that they've just practiced in the previous 8 sessions, the imagery and the context, in real-world situations. So in session 9, the client is provided with a list of 20 items to be purchased at a supermarket, right? So we've all done that with our patients, right? We want to see how they can kind of group them together. The client is then to use that imagery and context to recall as many items on that shopping list as they can. And again, they get that additional practice within each session to be able to do that. And then the last session, in session 10, the client is provided with 10 tasks or errands with keywords capitalized. Again, the client uses the imagery and the context to recall those 10 tasks and those errands. So the hope is that through repetitive practice right? That goal is for that client to start generalizing this strategy into settings within the home and the community to kind of strengthen their memory skills and their recall. So just kind of keep in mind that this is only one of just a very few evidence-based treatments. So the average clinician is really going to need to use their own skills and clinical judgment to generate other functional tasks and activities that target those underlying skills. Now, I'm certain that you can probably use kind of like this protocol and develop your own stories and your own word lists, and maybe you can even tailor them to your own clients. But it is evidence-based that it has actually been very helpful to teach those two different types of strategies, basically.
Well, that makes me feel better because the gentleman that I was talking about, his one big thing that he would come in, because he liked to be the first appointment of the day. So it was at 8:20 a.m. session. And so his thing was he would come up, we were on the 3rd floor and it was all the way at the end of the hall. So he would park, he would come up the elevator, he'd come to the end of the hall and he'd get down there and he'd say, now the parking lot was at the other end of the hall, not at my end, at the other end. And so he would say, I can't remember if I locked my truck. So we worked on that in that same way, not as many steps, but visualizing, okay, next time you come in, I want you to think about, okay, these are what I need my, he had a notebook he wanted to carry. I need my notebook. I want my phone. I have my keys in my hand. I've visualized that I've closed the door. I've hit the lock button on my truck. And now I know that it's locked. And it took quite a few times of him practicing that to feel like he was successful. But for him, that was a more practical means of doing it because he really had, it was almost like, again, the psychological component of anxiety that he may have had some pieces of things that he used at work in the truck that were valuable that maybe if it was unlocked wouldn't be there when he got back. And so for him, it was really a work in progress of kind of talking down the anxiety, helping him to understand it's okay if you didn't lock your truck. How do we fix that? You can walk back to the other end of the hallway. And even if you need to go down the elevator and go out front and lock it, that's fine too. But how can we work that into your routine? But it was really a struggle because this was a guy who, again, had owned his own business. He was very well known in the business world of what his he had a proprietary product that he taught installation procedures and all over the country. And so for him, it was very personal that he would not look, as he said, stupid to his clients or his colleagues. So it was very off-putting for him to be experiencing something that for us seems like it would be really simple to fix, but he kind of was in that rabbit hole of, I don't know what to do. These things are happening to me. I've given up these volunteer responsibilities at my church, and kind of like this whole whirlwind of things that he was experiencing to try to figure out what do we need to tease out immediately, because safety was a big issue. So we kind of started with that. So I'm glad that you said that because I wasn't aware of the specific protocol, but I knew that the visualization and context piece were part of the evidence-based practice, but not to the extent that you described it. So I'm glad that you did that.
And isn't it just kind of validating to know, okay, what I'm doing is actually the right thing?
Well,
right?
that, and it actually worked. That was the best part. It actually works because for him, it provided a lot of relief. And I think for his spouse, it provided a lot of comfort because she was having her own health challenges and he was trying to take care of her. And they were just moving into this different space in their life of semi-retired. And it was very scary, I think, for both of them, for him to be experiencing all this on these multiple levels at the same time.
Mm-hmm. And you just brought up a point about how sometimes our patients, a lot of them will tell, I don't want to look stupid.
Mm-hmm.
And so, sometimes, you'll try to train your patient to say, well, it's okay to ask for repetition. Like if somebody asked you for repetition, would you think that there was something wrong with them? No. You'd say, of course, I'm more than happy to repeat that for you. So I think sometimes we tend to over magnify things when it's ourselves.
Mm-hmm.
But unfortunately, in the world that we live in, everyone's just really concerned about themselves. And they're not necessarily really looking to say like, oh, he's not the same person that he was before. Most people probably aren't even noticing.
Yeah, that's what I told him all the time.
Yeah.
And he's like, I'm reliant on my calendar before I could recite my schedule. I'm like, but no one is seeing that but you.
Mhm.
I use my schedule all the time. I have a calendar. We all use our email for reminders. I use the example, you said 20 items at the grocery store, and I was like, oh my God, I would never remember 20. I always say, if you're going for the quick trip, right? You need 4 or 5 things, and you can figure that out when you look in your refrigerator and you're like, I'm not going to write that down. I can remember. And you get
Mhm.
to the store and you've got 3 out of 4 or 4 out of 5, and you're walking around the store like, I'll remember eventually. And now I bought a bunch of stuff I don't need, or, it was on sale, buy one, get one. Let's do that. And you get home and you pull in the driveway, and that's when you remember that one item that you forgot because you didn't write it down. But if you had incorporated that motor movement piece,
Yep.
you more than likely would have remembered it. And that's an average everyday person, not someone just with MS.
Absolutely.
And I think when
Absolutely.
you can give those real life examples for this patient population, it's really helpful for
Yeah.
them.
And as I mentioned before, people with MS experience a lot of fatigue. So for them to go to the store and then come back and realize that they forgot something, they might be too tired to go back and get that one thing. So it's exactly what you said, kind of teaching them like, it's okay to write things down. It's not cheating.
Yeah.
It helps you. It actually helps increase your level of independence if you actually write these things down, as opposed to having to rely on someone else to maybe stop at the store and pick it up for you. So.
Right. Or they, like, I don't know about those of you who have spouses, but you get the text, is this the right thing, with a photo? And then I'm like already cooking dinner, and so I don't even have my phone, and it's like, what? I texted you. What kind of
Exactly.
biscuits did you want, or whatever?
So as I mentioned before, since there are very few evidence-based treatments out there, I thought that I would just kind of go over some things that are, just functional. And you might already be doing these things in your therapies, but if there's one thing that you hadn't thought of that you can walk away with like, oh, I'm going to try that, then hopefully this will be worth your while. So, obviously we need to get to know our patients, right? We need to know our clients. You need to find out what makes them tick, what motivates them, what's important. At the same time, we also need to use our clinical judgment to determine what exactly is feasible for that client to do. So sometimes there can be a discrepancy in what their goal is and in reality, what they actually can complete. So we kind of need to find someplace in the middle to meet. But once you kind of know all of these things about your client, you can pretty much turn anything into a functional activity that targets that underlying skill that they're having difficulty with. So depending on the deficit area that's affecting the person with MS, I'll just go over some suggestions and ideas that are functional for each of like the processing speed, the attention, and the memory. And that's really the key word here is functional, because if your clients can see the relationship between their real life and the therapy tasks that you provide, you're going to get better buy-in from them, from that client. And even like with their home exercise, if they trust you and they realize, okay, what she had me do here today, it's very much like what I would do at home, then there's a little bit more of a buy-in. So just because we're running out of time, let me kind of go through some of these. So for processing speed, if you have maybe a younger client or maybe even like an older client who actually used to play board games, card games and board games like Spit, War, Spoons, some card games, or if you want to do more of a board game, Scattergories, which is timed, and that works on word finding, right? That generative naming where you only have like a certain amount of time, or even Boggle. You can pull out your old Boggle set there and they have to generate words within a certain period of time. So sometimes just incorporating something fun into a treatment session can be helpful for them. I do love podcasts. I think podcasts are great, but if someone with MS had to sit and listen to my podcast, they'd be out probably within like the first 5 minutes because it's just too long for them. And their processing speed is just not as fast. So believe it or not, there are 3-minute podcasts that are out there, and the topics can range from news to inspirational options. You can go on YouTube, you can go to your Google Play Store, your App Store, whatever, and look for some podcasts that are a little bit shorter. Also, maybe just choosing something that your person, that your client does on a daily basis that they feel that they're not doing fast enough. It could be something like inputting data into a spreadsheet. They can time themselves, or you can time them and have them just kind of do that repetitive practice to see if they get faster over time. I had one client, a young man who he was a server at a restaurant. So we had him practice taking food orders. So he would come up to a couple of the clinicians, we'd be able to tell him, and then he immediately had to go over and take that information and then type it into, I just had like an open Word document, almost as if he had to like go over to like the tablet in the restaurant and kind of basically input his order. So you can really make anything functional for the client, and it becomes a lot more meaningful for them. If you have a patient that likes reading, I would say, and if they like to keep up on the news, unfortunately, we know that there's not a lot of positive things that are happening in the news nowadays.
Right.
But there is a website called goodnewsnetwork.org. Hopefully, most of you are already familiar with it, but they're great little short positive news stories. And again, just kind of keep in mind that our patients they have a degenerative disease process. They most likely are going to suffer some sort of depression. So even just to provide some sort of positivity into their day is always going to be a good thing. And then also just like kind of like the most unbiased news website that tends to be just more of facts and kind of like a little bit shorter is Reuters.com if your patient really does like to kind of keep up on the news. If they like to read, but not so much into the news, a lot of times I'll have patients always to read books all the time, but now I can't get through them. How about just maybe introducing them to like reading short stories or just excerpts from books like Chicken Soup for the Soul? There's like a 1,000 different chicken soup for the souls that are out there now that I guarantee one of your patients could probably find one of them that they would like. Or how about Don't Sweat the Small Stuff, right? So as I mentioned, people living with MS, just any little bit of positivity in their day can make a difference. Moving on to attention. Actually, it was a student of mine who introduced me to this website. And again, maybe all of you are familiar with it, therapyinsights.com. It's not free, it is a subscription, but it has amazing functional activities on there for speech therapists and also for OTs. So we found it's actually a voicemail activity where the patient has to sit and listen to some short voicemail messages, and they have to attend to just the pertinent information in order to be able to take that and then schedule events and appointments for that particular week. So again, it kind of shows you if the patient needs to have that voicemail repeated, 5 times, obviously they're having difficulty picking out what the most important things are. So it does really work on attention. If you have somebody who's like more of like a numbers person who like handles the bills at home, I've given my patients, like a month's worth of bills, debit card receipts, paycheck stubs, deposit slips, kind of give them a starting balance and say, figure out the ending balance at the end of each day. That's a really good attention to detail type task. And then for like more of like our hands-on type of clients, we actually have, where I work, we have a nice big cabinet where we keep like what we call like our inventory items, which are just like regular household items. We have, a whole bunch of detergent bottles, flashlights, Gatorade, we have books in there. And then you hand your patient kind of like an inventory order. That's just with an assigned inventory number. So it doesn't actually say what the item is. They have to reference the item number in the cabinet to what's on the list. So again, another real good attention to detail type task. For memory, in addition to using imagery and context, such as in the modified story method technique, if you're working on working memory, you can have them do mental math calculations for, say, percentage off on a sale item. And like I said before, I had that one young man who was a server in a restaurant, giving like food and drink orders, and then having them tell like another person later on. A really great functional short-term memory task might be have your patient look up details on an MS support group. And then they have to recall the information later in the session on the days and the times that that's being run. And for perspective memory, sometimes I'll say, I'll give my patient a couple of things to do and say, oh, by the way, at this time, I want you to do this. And I'm looking to see, are they going to use a strategy? Are they going to use their phone to set a timer or an alarm? Or you might have them maybe make a phone call to you and leave a voicemail a couple of days from now. Another good perspective memory task. For executive functioning, I'm just going to, highlight sometimes, again, like a household calendar task. Give your patient, if they have children, maybe it's the schedule for their sports team or club, how that person's going to manage their dinner every night when they have their kid in all these different activities. Maybe that person belongs to a book club. When are they going to do their household chores or grocery shopping, and etc. And then another thing I like to do for executive function that works on problem solving and planning is like a hands-on activity. And again, that's really for more of like our hands-on kind of people. So just as an example, I had an old like standing oscillating fan that we weren't using at home, and I brought it into work. I took the whole thing apart, and sometimes I'll just have a patient try to figure out how to put it together. So again, just works on good problem solving. And then for word finding and language, sometimes I'll have a patient generate like a list of questions, and we go out into the rehab center and we just stop people and they just conduct a survey. So again, that kind of works with them on being able to use their little script, but at the same time, when they get an answer, can they follow up with another question off the top of their head? I've had patients give short PowerPoint presentations on a topic of interest, have them share opinions, pros and cons on non-controversial, like current topics. Could be things like professional sports salaries, organic versus non-organic foods, artificial intelligence. And then sometimes I'll do like a role play. I did have a woman, she was so nervous about going to her child's parent-teacher conference that we actually just did a role play with her, and she actually did write out a script of the questions that she was going to ask. And then lastly, I just want to go over some compensatory strategies that can be trained in session. So you want to teach your patient to work at an optimal time of day for them. People with MS experience a lot of fatigue, so it's important to explain to them that they should do their most challenging tasks when they're likely to have the most energy. Some people are morning people, some people are night people, but they need to figure out what that is and do those challenging tasks then. As I mentioned before, it's okay to request other people to slow down or repeat information, and you need to really kind of stress that. Teach them to get rid of clutter. Believe it or not, having clutter around can be very visually distracting and can affect their attention. So having them put things back into their place, taking breaks. Even if you don't feel tired, people with MS need to take a break before they get tired. It's kind of the same thing with people that have had like a TBI. Teaching them you need to take the break before you hit that wall. And then also just training them on an information management system. So that could be a smartphone, calendar, planner. You know, as I always say, anyone can write something down in a notebook or a planner, but it's knowing when it's appropriate to write those things down and when to go back and look at that information. And then as you mentioned before, Renee, about breaking things down into smaller, more manageable parts is key. And then I think as speech therapists, we all know about semantic feature analysis, being able to kind of talk around a word and circumlocute if you can't come up with the word. And then my last thing I just want to finish up with is just other factors that can impact cognitive functioning in people with MS. So I've spoken about fatigue, but other issues with that people with MS may have: sleep disturbances. Believe it or not, restless leg syndrome is actually very common in people with, sometimes they have trigeminal neuralgia and neuropathic pain. Pain in and of itself is very distracting. They might have visual disturbances, spasticity, tremors, or even just bowel and bladder dysfunction. So all of these things can impact a person with MS's ability to focus and concentrate and process information. So while we're treating the cognitive skill, just please keep in mind that we also need to talk to our patients about these potential concomitant factors. And so if you can, you know, try to get your person set up with some psychological support, maybe a support group from the MS Society. And if you do have a young person who's working, most states do have some type of division of vocational rehabilitation services. And you can have them reach out to them, because maybe the person needs to have their workplace modified, or maybe they need to have modifications made to a vehicle. And sometimes that division of vocational rehabilitation services can provide that type of funding. So just remember, no two people with MS are alike. There's a good chance that they're probably going to have some sort of speech, voice, language, or cognitive challenges. Try to target their specific deficit areas with a combination of evidence-based treatment and functional activities. And always, always keep in mind that these people suffer from a lot of fatigue, pain, and incontinence, and these issues can impact your therapy as well. I thank you for your attention, and if there's any questions, I'd be happy to answer.
Yeah, and I'll actually give you a food for thought, just because this was, again, I'm teaching a TBI class this semester, and so when I'm running through these executive function tasks in my mind, I'm thinking about how those things are very related to those of us who do have a lot of experience with treating TBI, post-concussion syndrome. And you see a lot of those same things being so important And it really speaks to how our brain is wired and interconnected. And I think it's a good way to say, even if you haven't had a lot of patients with MS, if you have had patients with TBI, you do have that skill set in place. It's just translating that into what the patient's needs are. And a lot of what you said is exactly what I told my students this morning about making it functional. You can make the most seemingly simple thing. I had a TBI patient early in my career who wanted to make a protein shake. And our tasks were centered on making the ingredient list, figuring out the steps in the process, figuring out the equipment that we needed, and then where were we going to obtain all those things. And so it's the same sort of thing, maybe a little bit higher level for a patient with MS, where you're looking at their daily task and how they're able to figure out these steps in the process and the things that they need to get that ultimate goal and manage their time. So I think it's just a very interesting translation of our skill set as SLPs.
Yeah, agreed.
So I don't see anything in the chat or the Q&A, which usually means you've done an excellent job explaining everything. Someone did say, is there at least one article or book or website you recommend?
Sure. I can probably get to you, Renee, the article on the modified story method technique. I can certainly get that to you from Dr. Sharvalati. She's actually got a lot of research out there on this particular method.
And I think you mentioned the MS Society. That's usually a pretty standard referral from the neuropsychologist to the patient, is sort of their starting point, is to reach out to the MS Society, look at their website, see what resources they have, not just for your local area, but just in general for anything from their medications to their expected potential symptoms to how to obtain referrals for treatment. So that would be a great place, I think, to start too.
Yeah. And if they get, because the website for MS Society is pretty broad, just call the 1-800 number and just speak to someone, and they'll direct you to the right information.
Yeah. Well, thank you, Lynn, so much for joining us. This is a really good, again, it was the right day, the right time to kind of interconnect how the brain works and how we can make our treatments more functional, and how it really needs to be more patient-centered and tailored to what their needs are. So I thank you for that. Thank you again, Lynn, and we look forward to seeing you again.
If you have indicated that you are part of the ASHA registry and entered both your ASHA number and a complete address in your account profile prior to the course completion, we will submit earned CEUs to ASHA. Please allow 1 to 2 months from the completion date for your CEUs to be reflected on your ASHA transcript. Each episode comes with an accompanying audio course on speechtherapypd.com, available for a 0.1 ASHA CEU. And just for our listeners, get $20 off any subscription with promo code BRAINSTORMS20. SpeechTherapyPD.com is run by SLPs for SLPs. We've got the largest library of ASHA CEU eligible courses out there, adding fresh content every week. Remember, use BRAINSTORMS20 to get $20 off access to over 1,000 courses for an entire year. Head over to SpeechTherapyPD.com for more information and start earning CEs today. Thanks for tuning in to Brainstorms, Functional Neuro Rehab for SLPs. And don't forget, SpeechTherapyPD.com is your go-to for all things ASHA CEUs. Your positive reviews and support mean the world to us. We'd love for you to drop us a quick review and hit that follow button.